Hi, everyone. I'm Cynthia Charles, Vice President of Communications for the North Carolina Healthcare Association. Welcome to our It Takes a Conversation virtual town hall. Today, we'll be talking about transforming healthcare through innovation. This is the fifth in a series of town halls connecting health system and hospital leaders with the public to discuss what's happening in healthcare right here in North Carolina and to answer your questions. Today, we have participants joining on Zoom and on Facebook. For our Zoom participants, all lines will be muted during the program, but you can ask questions anytime by clicking the Q&A icon at the bottom of your screen. Our panelists will be answering many of your pre-submitted questions during the program, and we will also be watching for questions coming in from our Facebook viewers. And now I'll introduce our moderator, Dr. Nisha Mehta. Dr. Mehta is a radiologist based in the Charlotte area, and she's a writer and speaker on many healthcare topics. Hello, Dr. Mehta, take it away.
Thank you, Cynthia. I'm excited to be here today to talk about how North Carolina's hospital systems are transforming healthcare through innovation. Innovation can really be a buzzword, and it's hard to know what it means, and it can mean a lot of different things. It's become a word that we throw around a lot these days. We won't be able to talk about all of the aspects of them during this discussion, but we want to try to get into as many as we can. Specifically, what I'd really like to touch upon is all the ways that healthcare systems in this state are working to improve access to healthcare for our communities, become more agile in responding to the needs of the communities, reduce disparities, and ensure that every North Carolinian has access to quality healthcare. I think that the need for innovation has never been as apparent as it has been over the past year. And we've seen various hospital systems pivot and do various different things to get healthcare delivered under conditions that we probably couldn't have even imagined a little bit over a year ago. This pandemic has really brought those things into light, and we have a lot of opportunities to leverage those innovations for the post-pandemic area. So with that said, I'd really like to dive right into the discussion. And knowing that innovation is a big, broad topic, I want to make sure that we talk about the priorities when it comes to developing new ways to provide care to patients. I wanted to start with Julia. What is the Carolina's Health Innovation Institute, and how is it going to approach innovation related to care access and disparities?
Absolutely. Good afternoon, everyone, and thank you for joining us. So the Carolina's Health Innovation Institute, it's a new initiative of NCHA with our partners at the South Carolina Hospital Association and the Duke Endowment, a private philanthropy with a mission to strengthen communities across the Carolinas. And the idea behind the Institute is that there's innovation all around us. Our hospitals, health departments, free clinics, universities, long-term care facilities, the list goes on, of organizations and people that every day are coming up with new and creative ways to take better care of folks and their communities. We have enormous challenges in our healthcare system, but what we don't have is a shortage of dedicated people with passion and ideas. The past year has made this more evident than ever. So the issue is not a lack of innovation. The issue is that these committed organizations and individuals are not always well known. Their work is in silos and is often underfunded and under-researched. And probably most significantly, the people with the power to help make these innovative practices widespread, your insurers, regulatory agencies, policymakers, they don't even know about them. And so therefore, more often than not, these efforts aren't sustained. So where we see the opportunity at the Institute, and will remain singularly focused, is to support the people, the communities, and the organizations that are experimenting with better ways to provide care and have some level of evidence to suggest that what they're doing is working. They're improving the patient experience, reducing disparities, and lowering costs. So we're going to further evaluate their initiatives and then identify the barriers to making them sustainable. We'll then connect the dots among these incredible programs with the interests of state officials and payers to help make what is clearly the best practice, the sustained, spread, and standard practice across the Carolinas.
That's great. Now we'll look at the systems and start with Donald at Wake Med. Can you actually talk about what innovation means and where it happens in, outside, and across your hospitals?
Certainly. As Julia mentioned, all of us innovate. Innovation is paramount to how health and healthcare is delivered. And so for us, and I would suspect most organizations, it's a pinnacle piece of what we do for our goals. And innovation revolves around things as much as being the first integrated health system, the first to do an open heart procedure, but also revolves also around innovation for what we do around our continuous improvement efforts. And so such little things as reducing wait time and turnover time, and the need for having to leave a room to find what you need, redesign of logistics and those sorts of things. On top of that, then you've got the technology innovation. And so there are things such as telehealth, which has obviously been accelerated by the pandemic. But I'll tell you, the pandemic brought out innovation across all of our organizations, from our staff figuring out a way to be able to monitor patients without having to go into the room as much, to new ways of sterilizing equipment, to flow and redesign, and then broader around health piece. And so you've seen most organizations transition from primarily being focused on the healthcare to also partnering with all those organizations that exist around how we make North Carolina healthier. And so focusing on disparity, focusing on moving care from the inpatient setting to the outpatient setting to the physician's practice, and now more and more to the home. And so you'll see that continue. And yes, there'll be really exciting new drugs and new technologies and those sorts of things, but you'll also see a deep-seated effort around how across North Carolina, our health community works to increase access, as you mentioned. Obviously, telehealth helps with that, new types of services, but also being able to measure and use data analytics to create standard work that improves outcomes. And pilot projects and efforts are abundant across our state.
I'd love for anybody else to weigh in on what their systems have been doing as well.
Yeah, I'll jump in. Hi, I'm Carl Armato with Novant Health. And, at Novant Health, our mission is to improve the health of communities one person at a time. And I will tell you that innovation and technology is critical to our ability to deliver on that mission. I was thinking about just over the past couple of years of what we've been able to do with data and the power of data and analytics and predictive capability, and how it's helped us to fight COVID and know what zip codes that we should go into to bring not only resources, but information and testing and vaccinations to help different communities, particularly when you start talking about health equity and other opportunities to help people across all of our communities. The other thing that I've watched is, Donald made a point about we had used a lot of technology in the past on eliminating wait times and using predictive analytics, but now we're actually building cancer centers that don't have waiting rooms for people to come in and access, because of our ability to predict and help patients access care, again, at the right place, right time, and right price. But the other thing I was thinking about is the technology that we have now utilized to enhance patient care. So when you think about the innovations, so for example, using technology as a patient is going through a scanner in our ED that's having a stroke, and being able to take another 10 minutes off or improving the wait time to be able to open an occlusion by 10 minutes because of this technology. What we've watched is we've had 500 plus patients go through that capability that we've built and installed over the last couple of years. And those 500 patients went home with no disabilities. And there's many examples like that. For example, people with tremors that I'm watching with MR guided focused ultrasound, that we were able to get that technology, that innovation. And we watch patients not able to hold a cup of coffee, be able to drink a cup of coffee, sign their name clearly on a piece of paper. And it's just those kinds of capabilities that we can bring to people and to bring to our communities that I think could be really rewarding for years and years to come.
I agree. I think as a physician, it's amazing to see some of the advances that we've made and the scalability of some of those things. If we really are to work together to really push these things out and really maximize the capacity for us to deliver state-of-the-art healthcare as quickly as possible to everyone that needs it, not just people that have traditionally utilized the healthcare system, but really, people just making it clear to everybody what the potential benefits are from really maxing out this technology. Moving on, you've touched upon a lot of these things already in terms of pandemic innovations and care delivery, but Carl, I'd actually like to, just build upon that a little bit and say that the COVID crisis has pushed so many innovations to the forefront, both in and outside of healthcare. So what are some of the most substantial changes or responses that you feel that your team at Novant has made during this crisis?
I'm thankful that our team for years invested heavily in, for example, virtual visits. I was just thinking during the crisis, we were seeing 25,000 virtual visits a day. So if you think about during the peak of the pandemic, and we're still seeing a significant number of them, but I was also just thinking about the predictive capability and analytics that we invested in. So when you look at the dashboards that we had access to and the information that we were able to get in the hands of physicians and providers and our scientists that were then able to help us guide. And I'll give you one example. During the peak, we saw some of our Black and brown communities, they were testing as high as 30% with COVID. And what we decided was that we had to go into those zip codes immediately with more testing, more capabilities, more masking, more education. And when we got into those communities, within a few weeks of that intervention, we were able to bring those positive test rates down to below 10%. And we watched that predictive capability play out also with our vaccinations and getting into markets, into communities, into zip codes. But we could see that and see what was going to happen with supplies and our facilities and our people with this predictive analytics. And I think that was so valuable. And I'm hoping that all of what we've been able to invest in, that we can work with other healthcare providers and continue to build on this incredible data that we can then share with providers, clinicians, and administrators to really provide better services to our community.
I agree. I think it was great to witness how much healthcare systems were learning from each other and how much was working just from, a situation nobody had ever been posed with to everybody kind of coming together, sharing ideas and getting things out. Other examples that people could mention within their healthcare systems of just telehealth, video visits, community partnerships, hospital at home programs, dealing with health and equity disparities. I'd love to hear it.
Yeah, maybe I'll jump in here. I think what you just said is so important. And from my perspective, really innovation is about collaboration and coming together and getting diverse perspectives in a safe environment, frankly, to craft solutions. And so we've talked a lot about tools and the different things that we all have put in place or have. But I think it's really creating an environment where those tools can become effective and lead to the outcomes of interest. And so I think one of the things, one of our primary objectives is pushing care to home or as close to home as possible. And so we consider ourselves a regional population health company. And so the analytics and understanding the population, but then taking assets and capabilities to home or as close to home as possible is really important. And before I get into some of that, I think you just mentioned something, right? From home to ICU, the amount of innovation, and just I want to thank our care teams for just coming to that environment and creating solutions, because our ICU doctors and nurses had to learn how to take care of critically ill patients in a different way, in a different environment. And it's a really intense environment. And then building testing capabilities and all of the things. And so just a huge amount of support. I think we all would echo that to our providers, our nurses and team members that came and mounted an historic response to these set of issues. And so just a big shout out to our professionals and in our organizations in healthcare. But if I think about pushing care to home and taking these assets, telehealth data, and all of that, it really comes to me, the innovation that I saw, and I think is so important, is the intersection of public health, population health, which is what we brought to the table, and community health, and then creating environments where we're having effectiveness in the community, in the neighborhoods, literally in the neighborhoods that Carl discussed, that we could identify that had high risk of infection and a lot of spread. And so we were able to take new communication tools, new interventions, new testing, new vaccines into those environments and have a really profound impact. That just really brought our communities together. And then I think all of us would want to highlight how we all did that and how it was connected actually between us together, because we met frequently and connected to the state. And so we came together as an industry to interface with Mandy Cohen and her organization and the governor and the state's plan to make sure that we were building literally systems that could get vaccine and testing into our communities in a real meaningful way to address equity. And then lastly, I'll just say, in Eastern North Carolina, we have clinics in cities that are on islands. And so telehealth, electronic consults, and how we use these interventions to push care to our patients in their home or in the clinics in those environments is really just really important, but it doesn't supplant in-person care, right? Telehealth, it will not take care of everything. And so it's just an added tool to our ability to intervene and help our communities.
And I would add as well, I think that there's, I think we've highlighted the number of ways in which hospitals innovated sort of in the moment without a lot of notice, without a lot of resources and tools to be able to pivot and deal with the crisis at hand. And then I think there's this whole other category of the lessons that have been learned through COVID that it will inspire a new way of delivering care moving forward. And I think there's a whole lot of things you could put in that category, but one that's really stood out to me and where I see the hospitals really responding is related to the role of the family and how evident the role of the family and how critical the family is in healing, in the healing process. And just when you look at patients with dementia during, while there had to be visitor restrictions, those lengths of stay were twice as long as patients without dementia. And, you can just imagine that that's because of the need of having family members around to be able to maintain and support that individual and lead them to a better state of health. And so I think that coupled with, the reliance that we have on family members for translation services, for all sorts of things. And obviously these are things we've always known as hospitals and care providers, but I think it's there's a new focus and clarity on it now. And so hospitals are starting to transition some of their physical space to accommodate more families and greater family engagement moving forward once we're outside of the pandemic. And really just sort of fundamentally changing the way that they engage families in the hospital care setting.
I agree. I think that we have just seen so many great examples of the human side of medicine over the past year. And, the media has been able to spotlight some of it, but what they probably haven't covered as much as, for what it meant to us as professionals and people who are actually coordinating a lot of these efforts. They haven't really seen a lot of that behind the scenes work that really comes, how easily people were, or not easily, but at least how adeptly people were able to come up with these private partnerships to really be able to mobilize things into the community and do so in a way that met patients where they were, both emotionally and physically. So I think I'm really hoping that it will lead to some transformation in how we deliver care and bringing the focus back on the patient in terms of the patient experience in a way that's really productive. In terms of future priorities and a look ahead, we know that historically, North Carolina has generally actually ranked lower than many other states in both healthcare quality and access. When it comes to helping North Carolinians improve healthy lifestyles, especially in those, especially those in underserved communities, what are we doing? We had a question from the audience actually about just how if lifestyle medicine was on the agenda for innovation in healthcare in North Carolina. Dr. Waldron, we'd really love to start with you and get the rural perspective to kick us off.
Well, I think it's a great question. It's a little bit back to what I was alluding to earlier. And I think, you got to meet people where they are and connecting in a real way in communities. And I think that COVID really accelerated a lot of that, how we communicate and how we engage in the community with families and the community. So messaging and those kind of things. But I think it comes down to giving power to the community to craft the solutions that they need, because there are different issues in different communities. And so this intersection of population health and public health. And so a lot of the great work that our team members have done about extending ourselves into the churches, faith-based organization, having community events where everybody comes to the community to learn about COVID, but also to get their health screening and other connection and form relationships, because healthcare is about relationship. And then how do we educate on healthy behaviors and those kind of things? That can be done in the clinic and also through electronic assets, but really is most effective in person and with these groups. So it's about empowering communities. And then lifestyle medicine, we have a lot of activity in lifestyle medicine and health coaching and different ways to intervene. So I think that back in the day, when I was a resident and stuff, it was always about the doctor had to do everything, but really healthcare is a team sport. And so how we bring these different perspectives that are important, health coaches and nutritionists to create an intervention to try to head off care. Which I think is great, back to where we're all headed, right? With Medicaid, and I want to put a shout out for Medicaid expansion in the state of North Carolina. That would help us give access to a lot of the people that we serve, and also Medicaid transformation. I think the state is moving to getting to a good position where it's not just sick care, it's how do we prevent people from getting illness. And so I think we're all very engaged in that work, and I think we're all excited about continuing that work.
Yeah, I think, just to build upon what you said, one of the things that makes me really excited seeing the healthcare systems expanding into these arenas is really, there's such a need for good evidence, scientific-based information in the community in regards to a lot of these topics that clearly are very important to people. But in an age where, anybody can post anything on the internet, the ability for healthcare systems to really take the lead and provide information is so important.
Yeah, and I just wanted to segue off that a little bit. And I know Carl and Donald would echo this or could chime in, but I think what you just said is so important because, in our communities, it's about what I discussed, safety and creating a safe environment that's a trusted, so it's about building trust because when you're talking about marginalized communities, whether it's vaccine hesitancy, but there's a reason for lack of trust. And so how do we get the right message and have the right messengers and have the right dialogue to build trust so we can actually bring these innovations to the people that will benefit the most from them. And it's just a really important, and really hard work because it takes a lot of people to do that. You can't phone that in.
Yeah, I'd like to just follow up with that, Mike, because I think you and Donald and others and all of us are focused on, really, we all care about our communities. We care about how we're going to be able to help everyone thrive in the communities that we serve and beyond that. And what I was thinking about is, as we were having this conversation, is, we've used data in a remarkable way, but the power of it today to be able to influence health equity and drive outcomes that are different is incredible. And I've got two examples. One is what we did with congestive heart failure. Another was with pneumonia. And just zeroing in on exactly why there's gaps amongst our community in the demographics and the people that receive care at our facilities. What's the amazing outcome about both of those examples is as we launched, and what we have is these business resource groups that go into the community. Mike mentioned going into talking to churches and talking to community leaders, but they got real understanding as to why readmission rates were higher in both congestive heart failure and pneumonia readmissions from people that look like them and in their community having conversations with them. And what the feedback that we got back, we made changes to our discharge processes. We made changes to our follow-up, specialty care and other primary care follow-up. And with those changes, we not only reduced the readmission rates for all of those, that were brown or black in our community, but we also reduced it for every demographic. And I think that's a key point, is that we're not only eliminating the equity and the inequity in healthcare, but we're also improving the health of our entire community by taking on these efforts.
Yeah, I would also echo that. I think one of the key things is that transformation that you've seen from we want to be a big old place that everyone comes to when they're sick to an organization that's a partner to help drive health. And health has so much to do with things other than a hospital close by. It has to do with, as was mentioned, a safe environment, a job, an education, transportation, access to healthy nutrition and foods, and those sorts of things. And so you've seen within communities a much more connected approach to be able to do that. And for us, it started with our board making it a goal that we want to make Wake County the healthiest capital county in the country. And we partner with the county to be able to do that. We're the healthiest county in North Carolina. Yay. North Carolina is not that healthy, so it's not a big deal, but we've gone from number 10 healthiest capital counties to number 3 in the country. And so there are those metrics and data that you can work together to reduce infant mortality and educate around congestive heart failure and partner with those underserved communities. We're all organizations that those without hope and means come to seek care. But I think what you're seeing now is a much more proactive effort to how do we prevent that care from being needed. And it is not a health system solution. It's a community and a state solution to that.
So some great follow-up questions from the audience in relation to some of the points that you all have been bringing up. We've said that the pandemic has shown how important public health is. Do you foresee health systems investing more resources into community health and prevention going forward? And can you please expand on the population health innovation initiatives? How are we going to move more from reactive to proactive medicine?
Maybe I'll start on that. And I think that's what we've just been talking about, frankly, and I think so many different aspects about it. But if you really think about it from the pandemic perspective, hospitals and healthcare systems, we ran to the front of this problem, and our professionals and our organizations did that primarily from a population health perspective, because we knew that the risk of being overwhelmed and the stress that would put on our organizations was important, that we prevent the illness, right? So we were, and I was saying, a year ago, that's no different than diabetes or hypertension, right? It's just another disease that happens quicker. But and so I think most of us took a population health perspective in that, and then I think the other thing that the themes to just drive that point home that we've all been saying is that I think that it also built collaboration in our communities in a different way. And so we worked, we have a 29 county region, every health department, every community health clinic. We had frequent forums to talk about the shared interests. And so bringing the expertise of the different parts of the system together on a regular basis, I think is learning that we will extend into the future to deal with non-COVID illnesses.
Yeah, I just want to stress what Mike's saying, because the partnerships that we created with the different county public health entities and the people and has really been an amazing opportunity for us within our systems. And I will tell you, I think there's so much more we can do together. We were sharing data, information, we were giving and sharing predictive capabilities that some of the health systems had with the county public health, scientists and others. And I'm hoping that we take that approach to going after some of what we need to do to improve the health of all in our communities. And I think it's a unique, COVID brought us together, but it ought to keep us together to help so many others in our community that need access to remarkable and safe health care.
Yeah, and I think that's the opportunity to build on what's happened. I mean, we're fortunate. We have the county health department located right adjacent to our campus. And so you create that interdependency and relationships. Part of the reason our infant mortality dropped is because we partnered with the county to focus on that, to have one of the lowest infant mortality rates out there. And so we saw that also, as Mike and Carl mentioned, around how we have dealt with this pandemic. But it is no different than what we need to do to drive obesity down, diabetes, congestive heart failure, and all those sorts of things. And a lot of that can happen with better coordination around our community health departments.
I do want to say one other thing, because I think of the world and we're all feeling like the pandemic is becoming behind us. So I can't overstress the amount of innovation that it took all of us to mount a response, and that was felt by our doctors and nurses and lab technicians and everyone. So I just think we got to continue to remind how innovation happens. It's really with people coming together, and that's not done. And so, I think for North Carolina, we're having an active conversation right now about innovation around genomic sequencing of variants so we can build a surveillance system that protects our citizens. And so there's a huge amount, and so there's questions about data and stuff, but this is a whole new body of infrastructure and information and capability to be able to know what viruses we need to do genomic sequencing in, to have that infrastructure to share data across the state so we know when these new variants are coming out. And that's all happening. Last night I was on calls on that one. And so it's just this constant innovation cycle, but it really comes down to collaboration and bringing. And we're fortunate to have people like Carl and Donald and our health systems that we really, we all know each other very well because we got together every week during the pandemic, and sometimes it was hard, right? We had some hard conversations about how we're going to make sure we take care of North Carolina, but that's what we did, and I think that'll serve us well.
Absolutely. You guys remind me of one of my favorite quotes. It's a Henry Ford quote that says, "Coming together is the beginning, keeping together is progress, and then working together is success," right? Moving on to some questions from the audience about different areas of innovation. Is there innovation happening in data management and areas like data ownership, interoperability, and vendor consolidation? How is the source of truth for HIPAA patient information being protected, i.e. cybersecurity?
Yeah, I'll jump into that one just to let you know. We just collectively joined 15 other very large health systems across the U.S. and we're actually de-identifying data and sending it in. But really, the goal is to take the experiences we learned during COVID and how we could predict outcomes and capabilities to now try to turn it into personalized medicine and really figure out a way, how do we predict outcomes and capabilities for all different disease states, all different communities that, where we can get ahead of what people, you get at population health. The best way to do that is to take a lot of data with a lot of scientists figuring out exactly what we can do. And I looked at what Novant Health did on its own, and now I'm thinking about, yes, it's time for us to figure out how all of us can come together with data to personalize the approach to medicine in the future.
Does anybody else want to weigh in on that?
Well, clearly that's a big part of what information from the old days of charts and lab results and those sorts of things to now the ability to use data analytics to predict all the genomic sequencing and those technologies and capabilities all around trying to make sure that we protect the patients and families' information. We know the power of cyber hackers. We're seeing it. Healthcare was a target a few months ago by another nefarious group. And so it's something we all work very, very closely. We cooperate, but at the same time, how do we balance that protection around the true value of interoperability to be able to get somebody better care or prevent illness, injury, and disease if we're able to have the information of what was done at Novant when a patient comes at Wake Med or at Duke or at Biden. And so or the physician's practice, right? We've got so many physicians out there with a lot of valuable information that if we can get it connected, we can both treat the illness, injury, disease for that episode, but also share back what was done to help reduce the impact of that episode, but also to help lower the cost of healthcare. Because I just haven't had anyone tell me that healthcare just doesn't cost enough. And so at the end point, it's the way we're going to reduce the cost of healthcare is by keeping people healthier and figuring out ways to reduce the cost of delivering the care that is needed.
Exactly. Yeah. Particularly among duplication, the more that we can get some of that information out there. I know that that's on the physician level, often frustration, just not knowing what has happened in other places. And so it is a tight balance between making sure that everybody feels safe. As you said, we're currently in North Carolina experiencing the results of cybersecurity in another realm. So definitely something very important and hopefully something that systems are really placing a lot of effort into addressing. Another question from the audience: what do you want or expect from med tech partners, not device companies, but in the post-COVID environment? Any thoughts about working with med tech partners to engage patients, deliver care, and reduce costs?
Well, just to build on what was discussed earlier, just a lot of innovation from wearables to in-home. Yes, some devices have to do with that, but it's also that ability to connect a lot of technology in a safe environment to be able to help us deliver care in the home, to prevent care, to, as Carl alluded to predict when somebody's at that range that they're going to need an intervention. Most of us have some type of predictive analytic to say when somebody's displaying signs of deteriorating in the hospital, so that we're able to intervene early and prevent patients that need to go to the intensive care unit. So it's how do we continue to build upon that? At the same time, we're all inundated. We all get hundreds and hundreds of emails every day from somebody selling something that's going to change the world and save $1 billion and save lives. And that's the challenge as well, is the amount of time and the ability to integrate all those things out there. So it's pick some partners, continue to communicate, and then move forward, because otherwise you'll spend all your time analyzing all of the capabilities out there.
Yeah, I think, Donald, you're hitting on it, because that's exactly what I see. Partners that can help us continue to advance innovation and information and helping us get it at the right place at the right time. I was thinking about all of the things that I see we're getting ready to invest in, these advanced sensors, and which includes like optical sensors and radar and audio sensors that we're going to be able to use that are AI-based models that in addition to that, we're also looking at how to help our nurses and our team members with more efficiency by introducing some of this new innovative technology. For example, having nurses wear smart glasses and being able to look at pharmaceuticals and being able to quickly determine whether it's the right pharmaceutical for the right patient. 3D printing for our patient education and our surgical service routines. I mean, there's just so much that we're going to be investing in with robotics and doing routine, capabilities. And so to have partners that are going to help us just make sure that we're automating things at the right place, right time, and we're gathering the information needed to get in the hands of providers and administrators are going to be important.
Absolutely. And we're such, a huge industry, obviously, in terms of numbers. And there's a lot of people trying to innovate in that space and with some really great ideas, and figuring out what the best ones to deliver to the community and how best to do so is really exciting. It's also a little intimidating, but definitely very exciting. Joy,
I was just going to say it is. And part of the challenge is you've got a lot of people that want to enter it. Some with the best intentions, some with not. I mean, it's a multi-trillion-dollar segment of our economy, and so that creates a lot of interest by folks that want to come in, reap some of that, and then move on. What's on the panel now are people that are going to be here for 1,000 years, that invest where there isn't always a return, and we do collective efforts to make a difference. So it's how do you balance who's that right partner with who's there to kind of turn things upside down and then move on to the side. So that's part of the innovation challenge as well.
Yeah, I totally agree with that. And I think it's really important that we remember that North Carolina has the second largest rural population in the United States, with over 3 million people living in rural environments. And the last mile is a real problem, and having technology and all of the really exciting stuff that we just talked about potentially leads to a division in our state and in our country, because there are a lot of people that they can't access educational assets or health assets or even economic assets because of the environment that they live in. And so how we connect to those environments and make sure that we are dealing with disparities in equity and extending care. But that means sometimes infrastructure that's not currently in the environments. And so, we've alluded to a few things, but a huge amount of work with extending our home monitoring capabilities during COVID to keep people out of the hospital, right? Well, that plays differently in our urban environments than it does in very rural environments. And so I think sometimes innovation is not technologically based. It's based in data and a lot of the things we talked about, and then sometimes it is technology based, but often it's not. And so we don't need technology necessarily to deal with disparities in equity and access in some of our environments, but we do need the understanding and from a community perspective of the issues, and that we learn from those issues and that we resolve those issues, or that divide will continue.
Yeah,
Mike, the only thing I just want to push on a little bit is that I've also watched technology get into rural areas that can actually bring capabilities that might not once exist in those areas. So for example, I was thinking about, from our perspective, us helping bring technology to the to those areas where, for example, our neurostroke people being available, where we can keep patients in those communities because they've got that kind of oversight and capability, or the behavioral health and being able to move these Zoom monitors into rooms and be able to offer behavioral health services where they once weren't located. So I do think that it's a balance of both of what you highlighted is, yes, we got to understand what the need is, but then second, we got to figure out also how to make sure the capability of service is there and available for those communities.
Yeah, there's no question. I agree totally. So all of our hospitals, are stroke ready, like you described, with telestroke capabilities, telepsych,
Right.
and a system. And I think that's a system that brings it together in a meaningful way, that supports our clinicians locally as well as being able to do it centrally. So totally agree with all of that. But if you also extend, that's to the hospital, but then you got to go out the next ring into the home, right, and to where people live. to really get a lot of some of these more advanced technologies. So I bring it up more that, and I know you agree with this, right? That I have urban environments and worked a lot in urban environments and rural environments, and the issues can be different.
Oh, absolutely, absolutely. And I've always said that each community healthcare is delivered locally, and you've got to truly understand what the needs are in that particular community.
I think what all this speaks to me is that there's identifying what that long-term goal is, what that need is, and what the goal is in order to resolve the need, and staying laser focused on that. And there's technology, there's all kinds of stuff that will come into play to help achieve that goal. But it's also very tempting to get kind of caught up in the swirl of what those new offerings are going to do. So staying focused on that is one of the things that we've done recently with the pandemic and sort of the hospitals and communities' interest in implementing a hospital at home model. And that's been around it's one of those things that's been around for a long time, but we're paying attention to it now more in the pandemic because we're really understanding how this can be valuable. So it's really providing hospital level care in people's homes. And obviously that requires a ton of technology. It requires a ton of coordination across different entities. It's very complicated to pull this off well. And so what we're doing is pulling together a learning collaborative across the states to sort of better understand, for folks that are trying to do this, what are they learning from it and how can those lessons be applied more broadly? But again, with a much broader long-term focus of how do we provide care closer to home for patients long-term, because we know that improves outcomes and lowers costs. And so hospital at home may be a good model to do that, but there may be some other variation on the model.
Right.
There may be pieces of it that need to be tweaked as long as we stay singularly focused on that goal.
I have an important question coming from Jessica Gunn from Greenville, who asked, how should we best handle fear about vaccine? Mike, do you want to take that?
Well, it's a great question. Shout out to Greenville, and hopefully she is listening and has visited our vaccine centers. I think the main thing is to get good information about the facts around the vaccines, and so Facebook probably is not the place to go for that. And I think interestingly, and I would like Donald and Carl to weigh in that, but when I look at just the facts, the science and everything, there's no question they're highly safe and reliable. And then having trusted communicators to the audience that connects to them. So and in that, I think interestingly for our data, the highest group of our professionals that have been vaccinated by far are the physicians. Over 90% of our physicians have been vaccinated. And being a physician, I always tell folks, my patients, that if you really want to know what a doctor thinks, ask them what they tell their mom, their dad, or their wife. And that's the real answer, because it's easy to get lost in all the noise, right? Oh, I hear this and stuff, and so just say, hey, doc, what would you do if I were your wife? And the answer, I think, is clear from our data, which is the vast majority of our doctors, well into the about 95% of our physicians didn't need to be convinced. They know the data and they were at the first of the line to get vaccinated. And so I think your doctor's telling you the answer.
Yeah, Mike, I think that's what I was thinking about what you were saying, because I looked at that right before I got my own, I got vaccinated, and the entire medical staff, about 95% had been vaccinated. And when you think about all those scientists saying, yes, I figured they had done the research. So I rolled up my sleeve and was ready to go.
Yeah, and I think that's how we started. Again, there was a lot of trepidation. If you'll remember, it was politicized a lot early on. But if you get trusted leaders and trusted scientists, and you look at the data and you're able to have the ability to be able to get your questions answered, and then their examples. For us, we did that. We sat down with our employees and did the same thing, and we've got a very high vaccination rate among our staff. And then from there, as we've all done, how do you reach out to the community, educate there? How do you reach out, as we've all done, to those underserved communities? Because again, we had a higher percentage of people of color in our ICUs and in our hospitals and testing positive for the virus. And so how do we get that vaccine out there? And so we got a group of our community leaders and churches and sororities and fraternities and our physicians of color to develop strike teams to be able to partner with community efforts to be able to do that. And when you've got people that they trust and know, and you're able to answer questions on the why and the risks and really engage them in that, we've seen that compliance and willing to get the vaccine rise dramatically as well. And we've been able to do that as communities across North Carolina, not where we need to be and yet, but we're making great progress. And in our community, those areas in particular have been important because they've been the most impacted by it.
Yeah, and I think it's an ongoing thing. And so I think that the thing is, people have to make decisions the way they make decisions. So you got to be accepting that and helping people, meet them where they are and help inform and a lot of the things that Donald said. And I think this next phase that we're looking at is really getting vaccines into our primary care and other physicians' hands in their clinics. And, talk about innovation, right? We all ran with really short notice that you will be the vaccinators of the people of North Carolina. And we literally stood up these capabilities in a number of days. And that was the first wave. But now it's like, how do we do a really innovative thing, which is a logistics management problem of getting this precious resource into these clinics? And for us, some of these clinics are on islands and in very remote places that need storage and other capabilities to get them into the hands of our physicians who want them so that they can have a very personal conversation with their patients and their patients' families. And so that's the next phase of this. That's what we will all be doing. And so we keep evolving and we keep innovating to meet the vaccine challenge.
Yeah, I've been so inspired by what all the hospital systems have done to pair with the community and get those vaccines out there. I think that was probably one of the most impressive public health accomplishments that I have seen in my career as a physician. I remember we actually took my kids to get my dad and my mom vaccinated because we wanted them to witness just how amazing it was that we were getting thousands of people through the system to get vaccinated. Natalie Ocean from Raleigh was asking, what lessons have you learned that will drastically shift patient care processes? Carl, do you want to start around the screen?
Yeah, I'll start. Obviously, we actually have some huge wins. We've talked about a lot of it today with innovation and technology. And our goal here now is to not lose any of that. I mean, we want to create remarkable healthcare for individuals. And we want to constantly look at how we've utilized technology to give patients and communities more options to access healthcare, whether that's through this innovative technology or face-to-face. But we've got to offer and continue to offer a lot more of these opportunities to serve in a much more convenient way. So when I think about all of this great technology, all of this predictive analytics and the capabilities that we have, is how do we meet people where they are? I think we've said that today, is how do we meet people where they are with their healthcare needs, and we personalize it to help them access healthcare where they live and where they stay. So I'm excited about what the potential is of harvesting all of these gains that we've made during this pandemic to be able to offer it regularly to our communities.
Absolutely. Julia, can you weigh in as somebody who's just on the forefront of innovation in the state?
Sure. I think there's, again, so many different areas in which you see this, but I would say one that is very prominent right now and is being discussed very regularly is around disparities in care specifically. And, it's another one of these issues we've known for a long time, but just has become very, very clear through COVID. And that there are variations throughout the system. And these are things that just need to be dealt with. It just is what it is, and it needs to be dealt with. And so I think one change that you'll certainly see in North Carolina hospitals moving forward is a real intentional effort to collect better data on this and to be utilizing the data to better inform practice changes within the hospital to improve and to reduce those disparities that we're seeing in the hospital. So that is a very intentional active effort that, you know, is just sort of, it's not just starting, but it's starting sort of in this new wave with new information from COVID. And we'll, you know, and it's going to take a lot of time and a lot of effort and a lot of experimentation and a lot of dialogue to try to figure out, why do these disparities exist? What tactically can be done to actually improve them? And what is the information that we need to be collecting on a regular basis to better understand why they're there and how it needs to be changed and who that needs to be communicated with? And then I think probably one of the most important things is, how do hospitals better engage communities in that conversation? And so that's a change that I very much anticipate is going to happen over the next few years.
I want to thank the audience for just all of their participation and the great questions that they've had. And I know just listening to all of these questions and the answers provided, I feel really good about who we have leading innovation in this state. And there's just so much going on. I'm sure we could talk about this for hours, but what I would love to do right now is actually just kind of end with just wrapping us up by asking our panelists what inspired them to get into healthcare, because I think that's really important when we talk about who's leading innovation. We kind of want to know where you're coming from and what your perspective is. Would anyone like to kick us off?
I'll be happy to start. I was hoping to find a cure for baldness, so I thought if I got in there, we'd be able to do that. Sadly disappointed. Now, I would say for me personally, and I think there's all kinds of reasons why people do it, it was what I had seen in my home, in my parents. My father was a medic during World War II, came back, went to nursing school, went on and helped teach healthcare leadership. My mom was a psychiatric nurse. And so within my home, healthcare and service to the community and service to the forgotten and focusing on how we get better and innovate and drive change and leadership was just what I had seen and experienced. And so even though my pathway didn't start there, it's where my heart was led. And it was just because of what I'd seen, and my whole family was involved in some type of healthcare and service to the community.
Yeah, mine was a kind of interesting aspect is, you know, at 18 months old, I was diagnosed as a type 1 diabetic. And, you know, over the years back then, that was before glucometers, I was always facing challenges in the early days. But I remember a moment when I was probably about 15, I was in getting my retinas checked, and the doctor asked me what I wanted to become. And I told him a CPA, and he made that sound as he was looking at my retinas. He went to, I don't know, you know, most type 1s or most diabetics I see after about 20 years, they have trouble seeing. They end up going blind. And I was just devastated. But I got home, and I remember my dad asked me a question. He asked me what was wrong, but he asked me to kneel down with him, and there was a 2-part prayer. The first part was just having the talent to be able to manage the disease. But the second part was really interesting, and I never forgot it. I didn't understand it as a 14, 15-year-old, but he said, really, he asked the Lord to allow me to utilize my diabetes to help others. And I'm confident that I'm sitting in this seat because that's what I'm here to do.
Yeah, well, so I was growing up in Rochester, Minnesota. I saw what a system of care can do for a community, and I wanted to help people. So I became a physician and then an epidemiologist, and I run hospitals, and my passion's around safety net organizations. And so it's all been about taking care of people and communities. And I'm excited about what we've learned through the pandemic, because I see an alignment of objectives and incentives and coming together from payers to providers to drive us to actually deal with some of the systemic issues that we've talked about, equity and disparities, and reaching into our communities. So I'm excited about healthcare and where it's going and our ability to do why I went into healthcare, which is taking care of people.
I guess for me, so continuing the theme of the influence of your early experiences in family, my mother was a middle school guidance counselor for 30 years. And so my early career was in special education, inspired by my mother, and then as a social worker. And I think over the years, I'd worked with children and families with tremendous social, emotional, and behavioral needs that were unmet by the systems designed to support them. And so I believe good healthcare can really change families and communities. And our problems are systematic, but they're fixable. And I fully believe it is worth the effort to fix them.
Well, that's all the time that we have, but I'd really love to thank our panelists, Carl Amato, CEO, Novant Health, Donald Gitzing, President and CEO, Wake Med Health and Hospitals, Michael Waldron, MD, CEO, Vidant Health, and Julia Wacker, Interim Executive Director, Carolina Health Innovation Institute. I'd also like to thank all of you in the audience. And if your question wasn't addressed, excuse me, please send an email to communications@ncha.org. Today's conversation has been recorded and will be available for listening or viewing at nchealthcare.org. So please share with your community. My name is Dr. Mehta. Thank you for attending, and please join us next time.
Thank you.
Thank you all.